It is really my great pleasure to introduce a friend and wonderful colleague, Dr. Marie McDonald. Dr. McDonald is lecturer of medicine and chief of the diabetes section at the Division of Endocrinology, Diabetes, and Hypertension. She is also the director of the Brigham and Women's Diabetes Program here in Boston. And Marie has been just instrumental in helping those doctors who are dealing with COVID and with the diabetes epidemic going on during this pandemic. And she has put in place so many fantastic programs at our hospital. So it's my great pleasure to introduce her to first discuss a diabetes overview, followed by managing common complications. So Marie, take it away. Thank you.
Thank you. Thank you so much, Carolyn. I really appreciate that very kind introduction. And I'm very excited to be with you this morning, especially this year, because we're going to focus on cases, bringing the information that we've learned from guidelines and, as many of you know, the cardiovascular outcome trials that have reshaped our thinking about diabetes. And it's really hard to get through the nuances of these guidelines without talking about the actual patients. So what I'd like to do today is go through 4 cases, learn how to apply advanced therapeutic strategies to these specific patient journeys. Now, my only disclaimer is that we won't cover every case, and I know hopefully we'll have time for questions so we can talk about some of your experiences. So case 1 will be new onset type 2 diabetes in a patient with coronary disease, not an uncommon scenario. Case 2 would be a man with poorly controlled type 2 preparing for surgery. Case 3 is an elderly woman poorly controlled on a complex insulin regimen. And then finally, an older man with longstanding type 2. Sounds like your practice, maybe clinic last week, right? So what are the options? So let's make sure that we are on the same page with the current options, because there have been some slight changes. Now, this slide, it's complicated, but I think that it highlights the complexity of type 2 diabetes, remembering that our bodies have duplicate mechanisms to maintain a normal blood glucose. This is for survival. So it makes a lot of sense that we have all of these mechanisms interplaying to achieve a level of glucose. It also highlights that you can arrive at diabetes or hyperglycemia by several mechanisms. And in fact, what we know is that since these mechanisms work like an orchestra, when one falls down, really the sound, the sound is cacophonous. So the idea being that these mechanisms have to work together. Now, the pharmaceutical industry, not surprisingly in science, has really been able to address these defects aggressively with a lot of new medications, some old, some new. This actually is a more palatable list of drug classes that we now use, you and I, in practice, generally speaking. And you can see the reason, I think, highlighted here, why we often need to combine therapies, where the pancreatic insulin secretion, for example, may be defective. At the same time, we know that the incretin effect in the GI tract is defective, where the incretin is secreted to talk to the pancreas and talk to the liver to prepare the body for fuel. When these systems are down, it's hard to address them with just one agent. So, of course, on top of lifestyle and behavioral modification, these agents have been incredibly helpful for a lot of people with diabetes. Now, putting them together, so we have insulin providers. So the insulin and sulfonylureas are taking care of the pancreatic defect in type 2 diabetes. The insulin sensitizers, metformin and TZDs, they're still there. One of the 2 oldest classes, and then the incretin enhancers. And then finally, this unique group, the glucose excretors. So if we put them in those simple terms, we really have 4 types of agents that we're dealing with. And what I'm going to highlight on this potentially daunting table is a couple things. So one is that These are all listed in order of arrival onto the market. And so we can see that, generally speaking, the goal has been to provide patient-centered oral therapy. GLP-1 receptor agonists, now that we do have an oral version in semaglutide, but is generally speaking an injectable, but that has been a nice change of late. You can also see that the side effect profiles of these drugs have become a little bit more unique to the class, and this has added complexity to our plate because we need to understand these side effect profiles very well as we prescribe them. The other really important comment, I think, is that right now the pioglitazone, the TZD pioglitazone, which is really the only accessible TZD on the market, is the only one where we do actually have a concern for human cancer. And the FDA has, in the US, has identified a family history of bladder cancer, personal history, and maybe possibly family history of bladder cancer as contraindications to the drug. But otherwise, I wanted to clarify that there is no data supporting human cancers in the use of these other agents. And pointing out the GLP-1 receptor agonists, there is a black box warning for medullary thyroid cancer, which has only been seen in rodents. And the black box warning will not be removed. But I want to tell you that directly, that really we haven't seen a case of human medullary thyroid cancer related to the drug in any of the large randomized trials. So hopefully that's reassuring to you. So what is the new approach to medication selection and management in diabetes? And this isn't so new anymore, but I do see in practice it's hard to put it into play. I like the 6 Ps of personalizing diabetes medication choice that Silvio Anzucci from Yale he taught me a long time ago. But just to keep in mind, we do think about, does this patient need insulin? If not, and we'll talk a little bit about that, what stage are they at? And do I need a more potent agent? They're not all the same potency, and that comes into play. What about precautions, of course? And then I'm going to skip to practicalities, which I think tablets versus injections certainly plays a major role in patient-centered care. And perhaps price trumps all of this in many of our patients' lives. But really, I think the focus has been on the perks. Start with the perks, and then we can dial back down to these other Ps to figure out what option we should choose. So if you start with what other benefits the drug might give to this patient's life course, you can then go back to the other Ps and pick the right drug. Now, the perks really were derived from these cardiovascular outcome trials, and this slide just summarizes and reminds you the story that began in 2008 when the FDA did require drug companies to demonstrate cardiovascular safety for every single drug, even in the same class. And these common primary outcomes were, for example, this major adverse cardiac event outcome, including stroke and MI, and as well as gave us an opportunity to detect other secondary outcomes such as nephropathy and progression of renal disease. So without going through those trials, because you've heard about them already, I'm just going to tell you the translation to the guidelines so we can get to our patients. So in 2019, we saw for the first time the big change, number one. The first one was choose your next drug after metformin based on cardiac and renal status, and really nothing else for the moment. Start there. So if atherosclerosis predominates, then especially, for example, a patient with an MI or a stroke, GLP-1 receptor agonists have the most clear benefit in that regard, in that area. SGLT2 inhibitors also have cardiovascular disease benefit and mortality benefit, but probably, as you'll see in a couple slides later, probably would be the second choice, although you can do either or, okay? We'll go into a little more detail around these drugs, but just to give you a big picture, heart failure and CKD, if that is the predominant condition in an individual patient, then we would preferably choose the SGLT2 inhibitor, which acts as somewhat of a diuretic, but also works to protect the kidney in the setting of CKD, but probably also in heart failure. So that's the major change we saw in 2019. And I'm just going to go back a moment to point out that if the patient doesn't have either, then I think the book is still open and you can choose based on other factors, okay? Now, the big change number 2 was that in recognition of the large trials demonstrating that GLP-1 receptor agonists, when titrated to max dose, are as effective as insulin therapy, and specifically basal insulin therapy, so the once a day long acting. So we can't ignore that data anymore. So the ADA has now said, let's think about GLP-1s first before insulin in the vast majority of cases. Cases where insulin must come first, I think you've seen those patients. They are losing weight, they feel very unwell. They may not have type 2 diabetes. They may have primary insulin deficient diabetes with severe polyuria, polydipsia, and that patient needs insulin therapy. We'll talk a little bit more about that because the cases, I think, paint the picture for us. Highlighting, though, for you also is the European Society of Cardiology. The ESC actually won the award for the most dramatic guideline statement last year when they said, actually, I think metformin should take a back seat. We have all this data for SGLT2s and GLP-1s. Why do we need to go to metformin first in people with cardiovascular disease and other end organ damage like renal disease? So you can see in this image from the guideline, the SGLT2 inhibitors or GLP-1s were put before metformin in those with those conditions. Now, the ADA has not agreed with this, and I think mainly because metformin actually is the foundational therapy in all of those large cardiovascular outcome trials. So in truth, we don't really know how an SGLT2 inhibitor behaves without metformin, if you think of it that way. So because of that, I think the ADA is still sticking with metformin as front line, giving everyone here a sigh of relief that metformin's still in front. But what's in the back is the A1C. This is interesting. So instead of thinking only about potency, as I mentioned before, we're going to start with the perks. So if beyond metformin, if there is a high-risk individual, instead of thinking, how am I going to lower this A1C, try to choose the drug that will give them the most benefit from an end organ damage perspective, okay? So again, we see this similar to the 2019 guideline that if ASCVD predominates, we're going to go preferably, now we're saying, to the GLP-1. And if the heart failure or CKD predominates, we're going to go to the SGLT2 inhibitor. Now, one thing I do need to point out, you're going to see here that that specifically eGFR between 30 and 60, this is where the data lies in treatment of people in clinical trials. The GLP-1 receptor agonists can be used across those GFRs. In fact, you can use a GLP-1 receptor agonist at lower GFRs safely with close monitoring. In general, the SGLT2s are not approved for GFR below 45. So I'm going to put that right up there. Now, for those of you who pay attention, there's one exception. Due to the Credence trial, the canagliflozin drug at its lowest dose, which is 100 milligrams, is approved by the FDA to be used in those with a GFR between 30 and 45 who also have high albuminuria levels, over 300 milligrams a day. So it's a tricky little caveat, and I think it's safer to consider, though, that for the most part, SGLT2s should be reserved for those with a GFR 45 and over. Okay, so let's learn through some cases. All right, this is our first case: a 52-year-old man with type 2, diagnosed 1 week ago during hospitalization for NSTEMI. His EF is 62%. He does have a previous history of metabolic syndrome, so hypertension, and actually dyslipidemia in this particular case as well. He has a family history of type 2 diabetes and coronary disease and peripheral vascular disease. On physical exam, his BMI is 35. His blood pressure is in good control. He's in the hospital. So good job. Normal cardiovascular and neurological exam. His admission labs indicate marked hyperglycemia. And sometimes that can happen independent of baseline diabetes in the setting of MI, but we have an A1C of 7.8. We're confident this man has diabetes. His LDL is 142. Creatinine is actually pretty decent. His GFR is 80. He does have a albumin to creatinine ratio of 18. So that's below 30. So we don't consider that in a specific risk category. And you can see his medications thus far have included the classical, we're treating him post-MI with statin, antihypertensive, beta blocker specifically, and aspirin. But what is missing, of course, is the anti-diabetic medication. So I'm going to ask you, first of all, what is the most reasonable A1C goal for this patient? Oh, this is a great engagement here. Okay. All right, I think we have a good answer here. Are we good to move on? Okay, next slide. Great. So the audience is suggesting somewhere between B and C. There's a little bit of A and a little bit of D. So I agree with you. In fact, under 6%, if it happens, we don't necessarily de-escalate therapies in patients who achieve, dramatic glycemic control, which sometimes people can, as you have seen in your own practice. So the idea here is this man is now set up for lifelong hyperglycemia, and our goal now is to protect him during his life course from excessive glucose, which, as we'll talk in the next talk, is really becomes a slow toxin for many organs. So I'm a big fan of getting him down as much as we can, if achievable, without hypoglycemia and too much burden, which we don't want to impose on patients with excessive medication use. He's young, remember, he's in his 50s. This is a great opportunity to make an impact on his life. Excellent. So the second question is more about management. This is a bit of a trick for you. So what would you recommend? I want to hear what you would like to do first. He's going home from the hospital. I think this is where we're at. Okay, great. So we have the majority of you advise metformin. Some of you are, it looks like the next is GLP-1s, and then SGLT2s is in there in the mix. So of course, this is the trick part. So A, B, and C are all reasonable. So that means you were listening, and they're consistent with available guidelines. Some would suggest that we should start with a GLP-1 receptor agonist in this individual because we want him to be on that medicine at some point soon. However, we don't have, as you know, the solid evidence to say that metformin should come second, but the guidelines do support this approach. I think metformin, starting with metformin and GLP-1 receptor agonists at the same time, you could run into trouble with side effects. So my suggestion to you would be to start with one of these and then add on, rather than trying to get to make room right away for both. But I think some people are using that term to make room for the cardioprotective agents. And in a young person with a new MI, we should think about the timing of starting a GLP-1 receptor agonist for his atherosclerosis. So excellent, excellent. Okay, what would you recommend if the baseline A1C was 9.5%? We're going to go to the voting again. So remember, his A1C is 7.8. Okay. Oh, interesting. I appreciate you voting. This is keeping you awake in the morning, right? This is great. Okay. All right. So what I'm seeing here is most people are seeing the value of combination therapy in this case. And again, I think the answer is probably best A and C. I don't think adding the SGLT2 inhibitor is wrong. But the goal here is to use a highly potent drug that'll get him to do two things for him. One will get him to his target, less than 7%, and maybe even lower, but also will address his obesity, which also has its own lifelong disability associated with it. The caveat here is maybe not start them at the same time. We do find, and you do probably in your practice, that occasionally metformin and GLP-1 together, you can't really discern what is causing the GI side effects. Both of these drugs have GI side effects. So the conversation might be to the patients to start one with rapid follow-up to start the second. But I'm a big fan of this approach, and good job. And just to remind you, I think that we're talking about potency in this case, and the SGLT2s fall somewhere. If this is actually a graph, it's compilation. This is not based on head-to-head trials, but it's the mean change from baseline in A1C levels, and you can see that SGLT2s fall somewhere between the DPP4s and SUs, or sulfonylureas. And as I mentioned to you, GLP-1s are in the same league as insulin, basal insulin, for sure, but even maybe biphasic, which is basal bolus in that premix insulin. So that is the rationale. Good. All right. We're going to exhaust this case, get everything we can. So what would you choose if this patient had a GFR of 48? His GFR, remember, was 70 in the first iteration. Would you be more likely, or would you be less likely to choose an SGLT2 inhibitor? This is excellent. All right, I think we'll stop here. So we have a tug of war here. Does the lower GFR drive us to this drug class, or make us a little more concerned? And I think this case is tricky because he's newly acutely ill, right? So I'm going to say more likely to choose, and I think I'll tell you it's related in part to my experience with starting SGLT2s soon after hospital stays. And we're seeing, as long as patients are monitored, that we see that patients do very well. We will explore in a case soon the concern about the SGLT2 inhibitors and acute kidney injury. But in general, in this case, because you are potentially able to address his cardiovascular mortality and his renal disease at the same time with this agent, it might be a more appropriate first to start. I'm certain that if there was a nephrologist on the case, they would recommend the SGLT2, and probably a cardiologist in addition. But there's more to discuss about that, and we'll talk about that, about how to make the decision beyond the perks. I do want to highlight for you that we do know that if you did choose GLP-1 receptor agonists in this case, you're still in putting the patient in a good position, because we do know the GLP-1s, if you look over to the left, when we compare placebo to the GLP-1 in terms of proportion of patients proceeding or progressing in kidney disease, GLP-1s are good. They reduce the risk by up to 15%, okay, the progression. But SGLT2s are better. And we see something more like 30% reduction in progression. So that's kind of the idea, that you might be able to impact cardiovascular and renal outcomes with the SGLT2 in your patient if the GFR is already low. So excellent. So what are beyond the perks here? What are the common positives? So for sure, the GLP-1s now, we used to say injectable was a downside, but there's an oral agent now, oral semaglutide or Rybelsus. There is better A1C reduction, weight loss. There's no hypoglycemia, as we mentioned, probably mostly the anti-atherogenic potential. And you can use it throughout all levels of GFR with caution. And of course, once weekly is nice. The SGLT2s, the common positives, I mean, it's really easy to prescribe. It's better for heart failure and CKD, especially in a patient who has both. Cheaper, much more easy to access for a lot of patients. And it doesn't depend on the beta cell. Remember, the GLP-1 actually does depend on the beta cell working. So even though we can use it in pretty advanced diabetes, it still depends on that. Whereas the SGLT2 is just a simple passive glucose excreter, right? Now, the common negatives are pretty important. So GLP-1s, we see nausea, we see higher cost, and again, less efficacy in people with advanced stage diabetes. But the SGLT2s, I would say, they're a little bit less potent for sure, but the genital mycotic infections, I think it's controllable. I prescribe these in people who can take care of their hygiene extremely well. But we do have to worry about volume depletion. And then we have these other rare conditions. Let's go into those. So for example, foraminal gangrene, I have a colleague who will not prescribe these because he feels that why put the patient at risk at all of this catastrophic event? It's still very rare. I haven't seen it in my own practice. In the cases I know of, the patient was morbidly obese with poor hygiene. And I'm just going to put that out there for you to select your patient wisely. The patient prescribed these drugs really needs to be in touch with their body and their perineum because this is obviously potentially catastrophic. It's just extremely rare. Now, what about DKA? I would put it in a similar category, very rare, although we saw 5 cases during COVID-19. Maybe Dr. Palermo will tell you about that. So it's not to be ignored. And what we generally recommend, since it occurs most of the time in the setting of fasting, patients are advised to stop these drugs when they are not eating and when they are sick. I say the same thing about metformin now. I put them together in the patient's mind, and I think it works. I haven't had a problem in my practice. So this is the summary, and I'm just going to say quickly that, when renal protection is a priority or in heart failure, I think SGLT2 inhibitors is the go-to. And then GLP-1 when weight loss is a priority. And actually, there's more advanced kidney disease. It may be the better option for you. Okay. All right, we're on to case 2. Let's see. We got some time. Great. So can I do this without insulin? That's the question. This is a 62-year-old man, type 2, suboptimally controlled. His A1C is unfortunately 10%, which was an oops discovery when he was being evaluated for his prostatectomy. So unfortunately, he didn't know, he was out of care, and the urologist calls and said, this patient needs to be under better control. So using this as an opportunity, we can evaluate his current regimen, metformin, max effective dose, glipizide max effective dose. He does check his glucose for you when he sees you, and he's reporting glucose is on average around 200. His goal, he says, is he wants to get his surgery done. He's afraid. Or he's miserable with his BPH. And patient goal number 2 is he wants to control his diabetes with the simplest regimen for as long as possible. So the negotiation was to start insulin for rapid titration. And we're not going to have an ARS question with this. I wanted to share the case with you. Rapid titration of insulin patients will do temporarily, and it's the right thing to do when you have a time-sensitive goal. This is actually output from his glucose meter, where you can see his average blood sugar dropped from 181 to 151, a pretty good average to get him to surgery without complications. So he's on glargine now, 26 units at night. And then, upon consideration of next step, we do want to consider the fact, and I think I shared this with you already, that in combination with oral agents, GLP-1s actually can be better than insulin. And so glargine is in the light gray, and you can kind of see A1C lowering is even better when you add a GLP-1 to metformin and a sulfonylurea. So actually, there's no reason to continue insulin. He didn't want to be on insulin. He gained weight. We switched him to Ozempic or semaglutide plus metformin, and he continues to do extremely well. His insulin was slowly discontinued. Okay. So I'm going to move on to our third case, which is the big mismatch. 78-year-old woman with long-standing poorly controlled type 2, history of mild cognitive impairment. She presents with her son. The key data here, she has a BMI of 32, her GFR is 46, and her A1C is poorly controlled. This is despite a home regimen that includes over a unit per kilogram per day, so 100 units at bedtime, Lispro 15 units with meals, and metformin, and 4 other medications that she doesn't know the names of. So one thing you may have heard me say, more than a unit per kilo per day. That's a good marker of a lot of insulin. It's not, many people need that, but when you see somebody on more than a unit per kilogram per day, especially if it's all mostly basal insulin, and they're not under control, you need to ask yourself and ask the patient, what's happening? Are they really taking their insulin? So first of all, here's an older woman. What is your A1C target for her? Her A1C is 9.8. Okay, great. I'm going to move on just for time's sake. So we have a nice split here. And I think that the reason why we have a split is because it depends. It depends on what's accomplishable. But I'll tell you what the Endocrine Society says. The Endocrine Society would say less than 8 and over 7. And the point being, in a woman who is likely going to need insulin, which I think is probably true, she has advanced diabetes, she's already on 100 units a day. We want to protect her from hypoglycemia, which is increased, the risk is increased with lower A1Cs. So actually between 7 and 8 is what I think a reasonable target is for her, especially if we can avoid hypoglycemia. So I'm going to just show you what we did. We performed a professional continuous glucose monitor, which is a simple procedure in the office where you put a little button. You may have seen the Freestyle Libre devices. It's similar. It's very similar to a button where we can place on the arm. We did that, and what you're seeing here after 2 weeks is this is midnight to midnight, and let's just follow what happens to her. Her glucose drops overnight. Actually, here's 80, so she's having low blood sugars at night sometimes, in the morning, and then during the day is very high. So when we talked to her, or actually when we looked at the day by day, we actually put together the story. It's sort of like a CSI episode. We found that she actually would go days without taking her insulin. You see this, this is all representing hyperglycemia. This is Thursday, Friday, Saturday, Sunday. Her son visits her on Sunday, comes in and says, "Mom, let me help you with your insulin." She gets her 100 units and she drops. And he's there reminding her, "Mom, are you taking your insulin?" She takes it another night. She'll actually take it for the next few days as she remembers. But then she remembers why she stopped it in the first place, which is hypoglycemia. She then goes into her pattern all over again where she doesn't take her insulin because she's afraid. She's also not able to really remember to take her meal insulin. So what to do in this case? I think that this is a case, even in an older adult, we have to think about GLP-1 receptor agonist therapy. Remember, we need a potent agent, right? And if we're going to replace some of that insulin. So how might we end up doing this? I'll just share with you, there's plenty of data to support the idea that if you combine basal insulin and GLP-1s, you can really achieve excellent control. You can see this reduction in A1C and in body weight. She does have obesity, which probably will impair her as she ages. And we saw this with both semaglutide and exenatide. So what did we do? Well, back to the case, we did prescribe once weekly dulaglutide, and we stopped the Lispro. She wasn't taking it anyway, but at least we know it's not in the medicine cabinet for her to mix up with her glargine. The glargine dose was reduced, and we used a weight-based dose. So remember that 1 unit per kilo is excessive. So we went to actually 0.5 units per kilo. We cut it essentially more than in half. And this is consistent with ADA guidance. And we went forward and we made sure everybody was aware of what happened to her. Her follow-up A1C was actually 7.8. And when we repeated her continuous glucose monitor, we eliminated hypoglycemia. Now, there's always a backstory, and she did have some nausea. She did not have vomiting. It was relieved by eating smaller meals, and she improved to intermittent mild by 5 weeks, which is really what the clinical trials have shown. We have not titrated her Trulicity or dulaglutide because she's actually getting to where she needs to be at a low dose. We also did make sure that we were measuring her renal function because she has, some people do reduce their fluid intake when they start this agent, not only their food intake. But she actually did quite well, and her blood pressure, in fact, was improved. Okay. Thanks. That was great. So let's go to the last case. It's called It's Time. Time for what? Well, we'll see. So this is a 68-year-old man. He is 84 kilos, and his BMI is 38. He's had type 2 for 18 years. Probably longer, as you know, because we diagnosed this disease too late in many people. He has non-proliferative retinopathy already with microalbuminuria of, it's not specified here, but his creatinine is preserved, his GFR is preserved. Relatively speaking, he has stage 3 to 4 CKD. And on glipizide therapy for 5 years now, 10 milligrams twice daily. And of note, recently, his A1C rose to 9%. Now, why he's on glipizide and not metformin is always a question, but these patients come to us, and it's usually because of side effects. But he's not doing very well. We did add metformin to see if we could improve, and it did improve initially, but we were struggling at this point now, 20 years into the diagnosis. He now then is reporting more symptoms. When we measured his weight carefully, he's actually losing weight. And he doesn't feel well. He does report that he's eating well. In fact, he's quite hungry. Okay. Now we look at his glucose monitoring results, and what do we see? Now, I know what you're thinking first. You're thinking, how did I get my patient to check their glucose like this? And I just want to let you know, most patients will do this for a short period of time. They will check their glucose frequently for a week to 2 weeks. And oftentimes that's enough information for you to go on to the next step. They will stop over time because they don't see the value. But don't be afraid to ask your patient to do this. So what do you see? You see two patterns. You see first, the fasting glucose is elevated. There's no doubt. That should be, in an older adult, somewhere between 90 and 150 in the morning. The ADA will say 80 to 130 actually, but we can move it up a little bit for him. The other pattern I see, the other big one, is that pre-dinner. That reflects his after lunch meal, or after lunch glucose. So whatever he's eating at lunch, we hope we can modify, but we may not be able to. All right, so what is the best thing to do in this case? Because we could do a few things. I think that we need a drug that will work in advanced type 2 diabetes that is high potency. His A1C is flying up. He's very symptomatic. How do you decide? So out of the choices, we can choose a basal insulin, adding to his oral agents. There's lots of evidence to support that. We could add pre-mixed insulin prior to his lunchtime, which is his big meal, maybe addressing both that pre-dinner high blood sugar and the next morning. We could also add a GLP-1 receptor agonist. There's nothing really telling us not to do that, except he's not feeling well at all. So I'm going to just tell you that insulin is the right therapy for this patient at this stage, given his weight loss and symptoms. Choosing insulin can be daunting even nowadays, where we have lots of options. Most of these options were designed for complex and advanced type 2 diabetes, but we still have the long-acting basal insulin analogs that are reliable and safe. So the ADA would suggest, and I agree, we would start basal insulin in this case, add the mealtime insulin later, or maybe even the GLP-1 receptor later. But he's insulin deficient. And I like to, the ADA suggests starting your basal insulin between 0.1 and 0.2 units per kilo per day. I usually go in the middle, especially if it's 10 units, which is easy for people to find on their device. And I often document in my note what I think the patient will likely need. And when I will say, hold up, I need to assess what he's doing, apropos of the prior case. If he's on 42 units and there's no budge, we have to assess if he's getting his insulin. And we need to really make sure he sees an educator to go through all of the steps. So we did start Lantus, 20 units. It did what we wanted it to do. We saw a nice reduction in his pre-breakfast, but we can see now if we don't address this pre-dinner glucose, he's not going to do very well, most likely. I'm going to go back to that case because it's wrapping us up for the case. And what I want you think about what you would do. I think in his case, it depends on what he wants, but we could do a GLP-1 receptor agonist at this stage. We could add insulin before dinner. Actually, the SGLT2 inhibitors is also an option because he has CKD. But now that he's on insulin, I know that he's going to feel well, he's going to be safe, and we can go from here. This is an easier place to start. Okay, so our key points. So we need to start thinking about making room for cardio and renoprotective agents in the highest risk patients. I think we went through cases. Using non-insulin agents in combination with insulin can be really helpful. And don't forget that. And I think that especially for reducing risk of hypoglycemia and maybe reducing complexity of an insulin program. Starting insulin at the right time is very important. And insulin's a wonderful drug. When we need it, it is there. And patients need to be happy about it. We need to help them feel happy about it. So consider referral of patients as far as next steps. Consider referral when you think that some of the newer the nuances are difficult, you want someone else to kind of back you up, and also to do stepwise simplification. I think that takes a lot of work, and a diabetes-focused specialist does that well. And then consider trying to adopt more continuous glucose monitoring in your practice. Okay, I have some references for you, and I would like to really end by saying thank you for taking care of your patients with diabetes.
Marie, thank you so much. That was a fantastic, clinically useful, full of pearls review of these new drugs and when to use them, how to use them. Thank you so much. We have a few minutes. I'd like to try to get in a couple of questions. There are a lot of questions, and then give you a little break before your next talk. So let me ask you one question here. Actually, two questions related to the goal of the glycohemoglobin, the hemoglobin A1C. Does it depend on the duration of coronary artery disease? Does it matter if the patient has coronary disease? So could you address, particularly for patients with CAD, what are your goals for the hemoglobin A1C?
Great. So we've only seen really in one trial, the ACCORD trial, where the A1C below 6.5 appeared to, the mortality rate was higher in that very high risk group. What I will challenge you on, though, is that in that study, we did not see the use of SGLT2 inhibitors. They weren't around yet, and GLP-1 receptor agonists. So most of the those who are arriving at an A1C below 6.5 were on insulin. It was around 75%. So we haven't been able to resolve this, but I do really feel that it's the hypoglycemia and some other nuances around insulin therapies that probably increase the risk in that group. So I'm going to just tell you that, and the guidelines say ignore the A1C in that regard in the patient with cardiovascular disease, as long as you're not on a hypoglycemia inducing agent, and treat them with the drug that we think will have the benefit. So I hope that's helpful.
Great. For the internal medicine board exam, which is the first choice? Metformin, SGLT2, or GLP-1?
It's metformin. You'll be safe.
Stick with that. Good. Does the oral GLP-1 work as well as the injectable?
Yeah. So the outcomes weren't as glossy. They weren't as glorious, I should say, because they used a different population and the trial was shorter. And I'm talking about the cardiovascular outcomes, but it works. It works really well. I'm pleasantly surprised. Patients must take it on an empty stomach with a 4-ounce glass of water. That's the only challenge. And that's not easy for some people. It's similar to taking bisphosphonates like Fosamax in the morning. So consider that once a week injectable is often preferable. But yes, it's a great drug. It really is.
Any concern about retinopathy with the oral GLP-1?
Right. Not different than the injectable. You can see advancement in retinopathy with tighter glycemic control if it's achieved rapidly. So there's great data now to support the reason why we saw a little retinopathy in the semaglutide studies. The injectable ones was related to rapid control. They enrolled people with an A1C of 10. So you should make sure that you have an eye exam and that there's a retinal specialist on call for your patient who you're achieving tight control in. No doubt.
Great. Thank you.